Welcome to our last lecture on the topic of drug addiction, which just so happens to be my area of specialty. I did my PhD work on cocaine, which is why I finished under 5 years. And then I went on and did my postdoctoral work studying cannabinoids, slowed things down a little bit. But I've also worked with opioids, benzodiazepines, um, uh, MDMA, alcohol. I have published with and worked with many of these drugs of abuse that we are going to be talking about, and have thought about these quite extensively, and would be happy to answer any questions that you may have. So first, I would like to just begin by reflecting on the cost of addiction, which is profound. We'll think a little bit about the financial burden on society. I mean, from a boss's perspective, you're certainly going to have employees losing uh, company money because of drug dependence issues. I have missed a flight once because it was the day after New Year's and everybody at the airport couldn't make it to work. So yeah, I mean the airport that I flew into just couldn't handle the plane switch on the first after New Year's. Just one of many memories, but that's really pretty trivial to the problems that you think of when you think of the overall economic burden on society, on the country, and then when you think about this in terms of the prison system and the incarceration problems that we have in the country. These are highly linked to drug dependence, as are STDs. The STD epidemic, especially HIV, has been linked to drug abuse and risky behaviors associated with drug abuse and dependence. Furthermore, you have a lot of people who are dying from drug dependence and drug abuse. Here are some people, who have famously died from drug use. This is certainly not a comprehensive list. We don't have all that much time. And one thing that I've noticed that's very interesting to me in teaching drugs, brain, and behavior at this school over the last 10 years is that I've noticed a shift in students' opinions related to drug use coming in the door, which has been very interesting to me. And it is primarily, I think, related to fentanyl associated deaths. When I first came here, cannabis was about to be legalized, and opioid, abuse wasn't as bad here, especially compared to where I came from, Baltimore, where heroin had already overtaken the city. But all the students were very pro decriminalization of everything. And now, I think that I'm encountering very interesting shifts in student opinion. And I think that that is because most of us, myself included, have been touched by people dying of drugs around us. Myself, I even know professionals. And that's also an interesting thing to keep in mind, that addiction, we tend to have some stereotypes, right? That the drug addicted individual is, the person that is homeless out on the streets. But, and while that is a small part of the problem, you might be surprised to recognize how drug abuse and dependence, how prominent it is amongst the professional class as well. These things manifest a little differently, but there's a famous ongoing case involving a lawyer in South Carolina right now who basically ruined his entire community and family, probably somewhat related to his own opioid dependence. He ended up murdering his wife and son. And this was, the leader of the community, I might add. And uh, and I think it even extends beyond that. And there's a lot of normalization as well. On Air Force One, I'd be willing to bet the two most common drugs given out are Ambien and uh, 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 little brain pause here. Uh, it'll come to me. Uh, but anyway, it doesn't matter. My point is that drug abuse is becoming normalized in certain pockets of society, and it is a very large problem in a variety of sectors in society. It, uh, but it is also worth noting that you know who we stereotype and target, regarding dependence and addiction, does matter, and we tend to sort of turn a blind eye or even sort of celebrate professional drug abuse. As I was mentioning before, it is not uncommon for private jets and even the president's jets to have some of these prescription pills ready to help you stay up and concentrate, or like in the case of modafinil, which is the drug name I was going for there. But yeah, I mean, modafinil is commonly used by professionals to stay awake, work longer hours. It's thought to be a sort of a safer form of amphetamine or methamphetamine, which your grandparents were abusing for a variety of reasons, but one of which was this idea that it might increase productivity. And at some point, what like does that also become an unfair competitive advantage, similar to an anabolic steroid? It is a problem, and I don't think it's reasonable that you should have to go off to medical school or graduate school and have to worry about do you have to take modafinil to stay even average at that point? So right, drug abuse is integrated or into some professional aspects of our society. Alcohol abuse as well, of course. That has a long history in professional America, and interestingly seems to be looked at a little differently there. One other thing that I would like to mention here is also sex, and that how sex has influenced drug use through the years, or how we have perceived the use of drug use as through the eye of sex, is worth considering. So first, it's thought most people, if I told you who is more susceptible to addiction, men or women, I think most of you might say men. Interestingly, the animal literature suggests that females, especially during certain phases of the estrous cycle, as sort of the rat equivalent to the menstrual cycle, show the greatest propensity to abuse drugs. Now, there could be societal reasons, of course, why women are protected from drug abuse, but I'm going to present an alternative perspective, and that is that women actually have been abusing drugs much more than men, and we just haven't called it drug abuse. So right. I mean, thinking all the way back to Civil War era, even back then, it was very common to give women opioids. Typically it was given in a tincture, sort of like some morphine and alcohol. And this laudanum solution would be typically requested by the husband through the doctor for the wife to help deal with all women's issues. Now, this sort of laudanum, or sort of doping up the housewife, was not considered to be a problem or abuse. And I think that sort of translated later into sort of a wine, alcohol martini era. You even saw, have seen portrayed probably in films of the almost glamorizing the idea of the martini lunch, wine with the friends at the houses, and so right there. My point is that the way I see it, it is at least possible that women have actually been abusing drugs and alcohol more than men in society for quite some time, and it's just not something that we've uh, noticed, and it's because it's just so accepted that yeah, we want there to be uh, yeah, it was accepted to have the so much alcohol in the home, and it was accepted and medically prescribed, I might add, to dope up the housewife in the old societal model of America. So this is something that I think is worth considering as we are moving forward socially. Now, our traditional sex roles are breaking down. And now we're also introducing concepts of, gender and thinking of things a little differently, which also, is a unique consideration as well. As is all of intersectionality and how, the combination of risk factors could make one much more susceptible to drug addiction and dependence, which is certainly something we are going to come back to. So, one good news that I have to bring to the table on this subject is that really for the first time in history that I am aware of, the roles have sort of flipped here, where the youth are the responsible drug users here, which I know that might seem crazy, seeing how most of you probably do know someone that has died of fentanyl, which is horrible. But but I think that's part of this trend, quite frankly. And so youths right now are uh, using fewer drugs than in years past, and seem to be using drugs more responsibly. Even when people are binging on these things, they are being a little more responsible with dosing and these sorts of things than their parents were. So, you guys have that going for you. Keep up the good work. There are still, problems. One is the realization that drug use trends amongst youth have shifted. So now rather than getting together to, I don't know, party like people did back in the day, you might go to a high school party where, everybody brings a bottle of prescription meds that they find at home and dump them out on a plate, and people take weird combinations of these things and see what happens. And, that, uh, right, is a different, form of drug abuse that, is no more safe than well, I mean, maybe, well, yeah. It is certainly not safe, especially when you take into account the combinations that can result from combining these prescription and over-the-counter drugs. And some of these can, I like, like dextromethorphan is an NMDA receptor antagonist. If you take dextromethorphan in high enough doses, it can produce effects similar to what you might observe with ketamine, another NMDA receptor antagonist. I mean, you can find over-the-counter and certainly prescription drugs that produce, very pronounced effects. So one thing that I would like you to reflect on is how we approach addiction as a society and as a medical community. So, things could be worse. I mean, there are countries out there that, will punish you corporally or put you in prison for 10 years, like Brittany Griner, for abuse of a drug or use of a drug, even. But what is crazy to me is that the medical community seems to generally accept that addiction is a brain disease. There is some debate over that. I don't know. I was trained at a hospital at an addiction center. So, I don't really understand the alternative views. I can speak to that a little, but I don't want to get completely off track here. So please let me know if you would like to hear more information about why, uh, you know, some of the alternative ideas as to why addiction might not be a brain disease, and what uh, it, I guess what I'm seeing as the difference between these ideas. But the medical community, when we approach addiction, we tend to, unfortunately, approach drug-dependent individuals as a problem rather than something that is our responsibility to treat. So if a patient, presents and first of all, about 1/3 of physicians do not ask patients whether they take illicit drugs. And, even if they do, 15% of physicians do not offer intervention to drug abusing patients. And what's more, I think that physicians are sort of wary of drug seeking individuals and just don't want anything to do with the situation. But I mean, try to think of it like this. I mean, like a drug seeking individual might be akin, if you accept it as a disease rather than a moral failing, which you should personally, you know uh, you can begin to see that uh, you know one of the problems is that the physicians tend to push the patient away. Whereas if you think of addiction as sort of more like type 2 diabetes, if you think like might be a reasonable parallel, there's certainly differences, but I don't think we are completely unsympathetic to the type 2 diabetic. We would probably treat the patient, maybe even show some empathy for the patient. But similarly, if the person has altered their physiology from abusing opioids, the doctor might tend to only see them as a potential risk factor and not want to associate with the patient, let alone offer them the help that they might need. So I do think that the dependence is somewhat of a failing of how we are approaching this problem, and just how we view it. It's a legitimate problem that needs to be handled with an open mind and without judgment, without so much judgment. I mean, it's similar to type 2 diabetes, similar to a heart attack. Somebody's presenting with is through life choices, and I say choice. I mean like through life experiences. Some patients might have experienced more things that would lead to cardiac arrest or cardiac, a heart attack. And should we be like, whoa, whoa, I mean, this person did this to themselves. I mean, this isn't my responsibility. This is only going to be a blemish on my record if this person dies under my care. Yeah, like people just don't even think about things this way when we think of heart attacks or diabetes. So why do we treat addiction and drug addicted people so differently? And here is a newsletter that came out when I was a grad student. I mean, this is, from back in the day, but it's something that, struck my mind on this, stuck with me on this related topic. So I just wanted to share the quote. This is about, a law. It's referring to the Uniform Accident and Sickness Policy Provision Law, which was adopted by most states in 1947. This law conceived on the premise that drug and alcohol abuse were essentially irresponsible involuntary behaviors had the unintended consequence of discouraging treatment of the addicted disorder. Many trauma and emergency room physicians do not even assess patients for drug and alcohol abuse, despite the fact that 40 to 60% of persons admitted to trauma centers had been heavily consuming alcohol or other psychoactive drugs at the time of injury. So now let's switch gears a little bit and talk about, addiction, how it progresses. So addiction is a process. It is a wrong belief that someone might use a drug on day one and become a drug dependent individual. Rather, there are interactions between, I like to teach it as an interaction between the drug itself, like how accessible it is, what is the price of it, how potent is it, these things are factors as well, the environment, and who you are as a person. So the idea is that the environment and things like drug availability can interact with your genes to induce epigenetic changes that can then fast forward or slow down the progression of drug dependence once you start abusing a drug. And like over time, that will lead to changes in the brain that will basically rewire things, creating a sort of more habitual drug-seeking, approach toward life. This is also commonly associated with changes that also reduce your ability to sleep when you're not on the drug. A lot of these, like for example, you would have to be on the drug to sleep. Like that is dependence. And that's actually one of the, few symptoms of cannabis dependence, which also, is a thing. Despite what some people say, there is actually a very clear documentation of a cannabis dependence. And yeah, like, so one of the wiring changes that might happen there is that, it just becomes very difficult to sleep if you aren't on cannabis, which, and then the fact that cannabis can alter your sleep itself and REM and these sorts of things, it becomes an issue, even though it might not look like as big of an issue as opiate dependence. So, when I'm referring to this as a process, I think of it as a process starting, before you were born. It really does start before you're born. Christopher Pierce at the University of Pennsylvania has demonstrated very clearly that parents' drug use can influence the epigenome of the child before they're conceived. So it is worth noting that, when you think of when you think of a planned pregnancy, you tend to think of the wife or the mother, taking, vitamins, prenatal vitamins, trying to do yoga, de-stress. They might make all these behavioral changes. And interestingly, the father, their changes, lifestyle changes actually seem to affect the epigenome too. So Chris Pierce has specifically shown this in the father, and he demonstrated that the offs. So first, he showed that so if the father was using cocaine before conception, that led to changes in the sperm. And that led to changes in the epigenome and genomic expression of the offspring. And this led to changes in their behavioral phenotype later in life. Interestingly, they seem interestingly they did not like cocaine, and that's an interesting one, right? They were less motivated to take cocaine, the offspring of the cocaine taking fathers. So, but the takeaway from this is not that the father should take cocaine to protect their offspring from cocaine abuse. In fact, I actually have talked to Chris about this, and I have a very different opinion or interpretation. My interpretation is that those offspring were incredibly anxious. And cocaine has both positive and negative attributes, including, a high degree of anxiety. Even regular users tend to report sort of approach retreat effects associated with the use of it, and oftentimes take other drugs like benzodiazepines or alcohol or cannabis, usually a combination thereof, to offset the anxiety and some of the negative symptoms that could come with cocaine dependence. So it makes sense to me that if the offspring were very anxious, they wouldn't take as much cocaine. But I think personally, I would rather my offspring be not anxious than possibly protected from cocaine abuse. But anyway, my point is that this starts very early on, and an influence of environmental, cultural, uh, and a variety of factors will start, shaping who you are biologically, to uh, determine how you will respond to drugs of abuse when they are introduced to you, and it all will just dictate how quickly you will progress from drug use to drug dependence. Now, again, you actually will be surprised to learn how few people that abuse drugs actually become dependent on them. It is not this high number that people might have told you to as scare tactics. I also don't believe in scare tactics. I believe in studying addiction based on objective data and being realistic about the entire phenomenon. But anyway, it sets the stage for what will happen when you were exposed to the drug, and then that can result in whether or not you can become dependent in 6 months, or whether or not you'll be so resistant to dependence. I mean, it would take 20 years of shooting up before you really, lose control. So, why does this matter? Especially for adolescents, it matters, quite a bit, because that's when drug abuse begins, right? So, and I think this is particularly problematic with possibly even cannabis. That there is a literature supporting the idea that cannabis use in adolescence can increase the risk of mental illness in susceptible individuals. Whether or not such things will happen, similar observations will be observed with psychedelic hallucinogens. Remains to be completely parsed apart, but I know where I'd bet my money. Right. So, in general, so where it shows up here on this arrow up here, showing that the frontal cortex ends development at the age of around 20. That's also not accurate. It's really around from a range of about 20 to 30. Your frontal cortex, like when adolescence ends, first of all, it seems to be getting older, and frankly, I don't think that's necessarily a bad thing. I think it's possibly even an evolutionary thing that, over time. And I mean, like, this is evolutionary theory that, in fact, we even touched on this in the beginning of the class, did we not? That, we've evolved to have longer development for our brain to develop complex processes. So, but what's more important and what makes us human in these cognitive processes than the frontal cortex, which is developing very late during this period where a lot of people have started to abuse drugs. And, it's playing with it's like Russian roulette a little bit. I mean, you know that you are going to produce some changes in your frontal cortex, and yeah, like when you are sort of plastic and can be molded during this formative period. Yeah, it's it is an interesting and most impactful time. Like I think drug abuse, it has greater impacts when during this period than in others, because the brain is still plastic and can be more greatly influenced. Right. So, um, Right. Adults generally rely on the frontal cortex more than teens do. So, again, speaking to the development of the frontal cortex, but also this is related to impulsivity. So, in late stage drug dependence, you actually stop you lose functionality of the frontal cortex. It's thought to be part of basically a degradation that sort of puts you back into this very simple habit formation loops driven primarily through your basal ganglia, where your frontal cortex is sort of off, and you're not really performing complex tasks anymore, not approaching things with the same level of awareness. So, and that is somewhat also a problem in adolescence, where the frontal cortex might not be as developed, and you're not being quite as, considerate or reflective or attentive to all the, variety of, things that might be going on when processing one thing, like reading a book. Uh, the uh, but yeah, the youth, similar to the drug dependent individual, wouldn't be engaging the frontal cortex as much. They would be relying on structures more like the amygdala. And this could lead to impaired decision making involving drugs of abuse, which again can have serious ramifications. Again, I mean, the National Institute on Drug Abuse actually sells. Uh, they go to Congress, and they have convinced Congress for quite some time to consider the HIV problem to be a drug abuse problem, just because so many people that end up contracting some of these serious sexually transmitted diseases did so through risky decision making during sex. Right, the idea that when things come up, like whether or not to use protection, if your frontal cortex is offline and you are impaired on a drug, that can be a deadly situation. Do adolescents react differently than adults to substances of abuse? The answer is yes. I mean, this is really pretty much across the board. It's also interesting to note that there's sex differences here as well. And again, I think that there is a general underappreciation of this notion that women, might actually have greater risk for abuse in society. And then, especially so I mean, like, but that's sex, and then especially if you bring into the concept gender, and some of the intersectional concepts that might come into play to a minoritized group, their risk and how the addiction process might be speeded up, can come into play. And these are most certainly things that I think we should look at a little differently moving forward. The idea that addiction is a male adult thing, is not accurate. So why do people take drugs in the first place? So this is very different when you start taking drugs and when you end taking drugs. So when you start taking drugs, it's to have normal feeling, like to have good feelings, and but there's also some to feel better. Oftentimes, it's been suggested that like people might self-medicate with various drugs of abuse when starting to experience some psychiatric malaise. So, there are two sides to the coin as to why people take drugs and how, but it sort of shifts more to only being about feeling better in late stage addiction. Right. So in addition, people abuse drugs because they engage motivational and pleasure pathways in the brain. So like it has been speculated that, or it is generally accepted, I would say, by the scientific community, that the we have motivational, what some people call reward pathways, not a term. My own research has been involved in rewriting that notion, so I don't want to say those words. So not brain pathway, but not reward pathway, but more motivational pathways that have what have we have evolved over the years to basically take environmental stimuli that will then drive us to seek out things that are highly valuable and uh, uh, help us increase our behavioral fitness by seeking out the most valuable commodities that our brain recognizes. Drugs of abuse tend to usurp these pathways, most notably the mesocorticolimbic dopamine pathway, which all known drugs of abuse act on. So this pathway, I've shown can drive us toward things that are rewards that are highly valuable, but it can also help us avoid things that, would harm us. So it's again not completely a reward pathway, but more of a motivational one. But anyway, drugs of abuse usurp this pathway. So if this pathway is there to tell you that this was the most valuable thing you've ever had, and if you get more of this, your life is going to be awesome. Like that's how this pathway is basically wired to work. And that works well when it's an A on a paper, and then your hard work has been rewarded, and you will go back and repeat, and you'll rise through the ranks and eventually be a CEO of Microsoft. Alternatively, the best thing that your brain has ever experienced might be heroin. In which case, your brain has been tricked that this is the most valuable thing ever, and will follow that path. Interestingly, I mean, advertisements work similarly. I mean, like the McDonald's arches would work similarly. Like in fact, it's a good analogy. I mean, the McDonald's arches are, they play off of this same structure in the brain to tell you that you're going to get this great value. In fact, they even call it the value meal. And then you go in and you order it, and you might be expecting, your brain is telling you you're going to get something great. And then it's just the same old quarter pounder with cheese, and yeah, you're very disappointed, you're very let down. And yeah, but there can be additional factors, like social factors, like Michael Jordan telling you that McDonald's is really very good and he eats it every day, even though probably never. But even though the advertisers, and they could be telling you or convincing, playing into this idea that you're tricking your brain that you are getting a better value than you are by playing on circuits that were evolved to improve your behavioral fitness by telling you to seek out the best value possible. It's also worth noting that drug abuse is highly comorbid with other psychiatric disorders. I've already alluded to this, and there's great debate over whether drug abuse leads to psychiatric disorders. This is a possibility, or whether people that are starting to suffer from psychiatric disorders then turn to drugs of abuse to self-medicate because their head feels off. I think it's both, but right. It is sort of a chicken or egg question. I mean, it's a little hard to prove one way or the other, right? Aside from the correlation. I mean, it's pretty easy to tell you that a lot of people with depression abuse drugs, and a lot of people that abuse drugs are depressed. But which came first? Yeah, I think it's the easiest way to think of it is just that it's a vicious cycle. That the two can play off of each other. So that is a problem. There are several reasons for high comorbidity or that have been explained. One specifically is known as disorder fostering disorder. Here, the person would be using the drugs to help cope with a negative affective state. So, I mean, this would essentially be the case of the mental issues coming before the drug abuse. In addition, you can have overlapping neurobiological pathways. So here, based on the premise that repeated disruptions of brain function by drugs sensitizes neurons that contribute to affective disorders, really the opposite, right? So here, sort of a fancy way of saying that, through repeated drug use, that's going to change the brain in a way that brings out mental illness. And again, this has been reported first, in a group of Swedish draftees. They found this really relatively weak correlation, I might add, but I mean, it is a noted correlation that a small percentage of people that did go on to develop schizophrenia also had, used cannabis in adolescence. But whether or not that doesn't prove one or two, it just shows that either one or two is probably happening. And I'm open to both. Finally, we have underlying genetic factors. This is also very likely. Families with substance abusers are more likely to have members with mood disorders and vice versa. So I also want to touch on some definitions. So I'm typically throwing around the term addiction. Addiction really isn't a medical term. The DSM uses the terms drug abuse and drug dependence. So what do all these things mean? By definition, drug abuse refers to use of any drug in a manner that deviates from the approved medical or social patterns within a given culture. Here are some specific signs of abuse you can read. Addiction is typically used to convey a quantitative rather than qualitative sense of the degree to which drug use pervades the total activity of the user. Addiction indicates a severe degree of drug dependence that is an extreme on a continuum of involvement with drugs. And I think this is very spot on how I think of it, which is more of like a linear progression, right? And whether or not you fast forward through that progression or slow down and maybe not even make it to the end of that progression depends a lot on your genes, your environment, your socioeconomic status, your social structure, the culture around you. And then you have drug dependence, a syndrome in which the use of a drug is given a much higher priority than other behaviors that once had higher value. In its extreme form, drug dependence is associated with compulsive drug-using behavior and exhibits the characteristics of a chronic relapsing disorder. Drug dependence, would typically, come after a prolonged period of drug abuse. And that would be the terminology in the DSM, drug abuse, and then drug dependence. So we already had a slide earlier that alluded to this, but this is, my preferred one from Drugs, Brain, and Behavior. So this is from a psychiatrist by the name of Charles O'Brien at the University of Pennsylvania. And, I guess I teach his model because it's what I accept. His idea is that essentially there are three main classes of variables that can fast forward or slow down the progression of someone along that linear trajectory of developing drug dependence following initiation of drug abuse. So, the first graph that or figure that we looked at had host and environment up top. And these things are certainly important. I mean, the host is who you are, genetically, and the environment is clearly important as well. I've lived in multiple environments that, pose unique risk factors. I lived in inner city Baltimore. There they have some unique issues with drug abuse and dependence. And the environment certainly plays an important role here. It is very well portrayed in the movie The Wire, which is incredibly realistic, in my opinion. Like it just looked very similar. Yeah, I mean, drug dependence is a very big problem in that area. And one of the saddest realizations is that there are a lot of children there that are essentially homeless, meaning that they don't have a regular family member to rely on. It tends to all fall on a grandma, and then there are grandmas, doing their best to look after quite a few children that don't feel that they have a very supportive social structure. And what is the solution to that problem? It's a hard nut to crack, and it's incredibly sad to see because that most certainly, if that uh, child used heroin, it would be a very different scenario than if the child of a wealthy suburbanite in Denver used heroin, right? Very different. And also condition stimuli play a role here too. Anna Rose Childress, the most famous student of Charles O'Brien, has done a lot of interesting work with conditioned stimuli in the environment. And she's found that in her drug dependent users, what she does is she'll send them out after she's helped them get clean. And then she'll hook them up with monitors so they can monitor physiological responses. And she finds that as the patients are returning to their regular home environments. I mean, like in Baltimore or in Philadelphia, where she is, similarly, there are certain areas where you can't help but walk on the, where I was from in Baltimore, they have these things, they put the drugs, at least at the time, they put the drugs in these little glass vials that they call beats, because after that, the glass vial would get smashed on the ground typically, and you'd be like walking on glass and you could hear it. And that like little crunch is literally a drug cue, right? I mean, that was the bag. uh so, and I mean, you see needles all over the place. I mean, literally on my way to work in Baltimore, I would routinely have to step over passed out people with needles sticking out of their arms. um and then I've also lived in the rural South, and wow, talk about a different scenario, different drugs, no support, um different problems, all bad on both sides. So that's environment. Host, I think we've got that down, but let's also think about agent here for a little bit as well. I mean, this certainly impacts things, right? I mean, like, why is fentanyl such a problem now? I would say at least part of that has to do with the uh, availability of the drug itself, the availability of fentanyl. If fentanyl is available at a very cheap price and you have a very highly potent opioid like that, then that can most certainly increase the speed at which the addiction process accelerates or fast forwards, right? Um, uh, and this is a very interesting and timely and relevant point because when we think about decriminalization and legalization, it's let's be honest and let's think about the agent part. I mean, like, does anybody really believe that cannabis use decreased when we legalized it here in America or in Colorado? And that, of course, was a common talking point before it was decriminalized. Drug use, would go down. And while drug use is nationally going down amongst youth across the country, that trend has not been true with cannabis use. Cannabis use is actually going up, whereas things like opioid use amongst youth does seem to be declining. But I think that's just associated more with deaths, which can be, a social environmental deterrent. Um, but yeah, the non-debatable part is that the agent can most certainly fast forward the addiction process. Now, whether or not decriminalization makes that better or worse
remains a topic of heated debate. And I'm certainly not going to try to convince you one way or the other there. Just I want you to simply think about whether or not how agent or the drug itself and its availability, its cost, its purity might play a role in facilitating the addiction process, and also how you use it. You know, typically when you take drugs in ways that has a higher speed of onset, that tends to fast forward the addiction process. So taking the heroin IV, versus like a methadone or like a liquid uh, PO per os per mouth route of administration could facilitate or fast forward addiction, the development of dependence even faster. But it is also worth noting that the majority of people that abuse drugs do not become dependent on them. Alcohol and tobacco are historically, this is from a while ago, but historically, alcohol and tobacco have been some of the drugs that have the greatest potential for addiction amongst users. And one thing to think about that is how that does relate to agent and availability. Uh, Maybe it's not related. I don't know, but it is just I'm a data guy, and those are noticeable data to me. But then when you look at illicit drugs, I mean, like you can see that even with things like heroin, uh, you know, uh, you know, 25% of heroin users becoming dependent is a lower number than I think most of us would have predicted, even though it is still quite high. So, one thing to note about this is simply that it is a process, right? I mean, like this is going back to this whole idea that there can be a lot of protective factors as well that can shield one from the development of, drug dependence. So this is just to highlight that, addiction is a horrible problem and a huge burden to society. I've already talked about this a lot at the beginning. So is treatment too expensive? These data, are very clear. It's been shown by various economic models that untreated addiction can actually have a profound impact on society and on really multiple levels, in everything from cleaning up our parks to just lost income at work to, I mean, again, I just can't get it out of my mind that I literally flew into an airport where there was nobody at the airport to deal with the plane because it was New Year's Day and everybody was wasted. Like, uh, I, I mean, it's just an insane scenario. But anyway, uh, you know, after untreated addiction, arguably the most expensive way to deal with addiction is incarceration. Incarceration now costs $45,000 to $60,000 a year, depending on the state that you're in. I think New York is the most expensive, and over 60,000 to incarcerate one person, which is, I don't know. If you could make $60,000 a year right now, would you quit school and take that job? Right. I mean, like, it's crazy that we're paying that kind of money to incarcerate somebody for abusing drugs, which, I personally see as sort of more similar to type 2 diabetes. I'm not going to lock up some type 2 diabetic for eating a donut. That sounds crazy to me. Honestly, it also sounds pretty crazy to lock up somebody for using heroin. And it's also just an expensive problem, an expensive solution. Probation or some sort of monitoring would be a cheaper alternative, but still more expensive than actually offering residential treatment. And then you have our sort of the cheaper ways of dealing with this, which are methadone maintenance and outpatient, psychotherapy. So yes, I mean, outpatient pharmacotherapy and psychotherapy, especially in certain states, that varies a lot. Like in South Carolina, where I lived, there were, at least when I was there, these ideas of government provided addiction counseling centers weren't a thing. Like, I mean, they did not really exist. Whereas, I mean, I think that sort of resource would exist in some states. Uh, Also, you see a lot of difference in how methadone and buprenorphine are given to drug users. Buprenorphine is typically given in Subutex or Suboxone. Suboxone also has naloxone added to it to, try to discourage users from injecting it intravenously. Naloxone is a mu receptor antagonist, and taken in that form, it's pretty aversive, especially if you're dependent on opioids. But anyway, there's also quite a few number of states that are against methadone maintenance, these sorts of approaches to dealing with drug dependence. And I also want to point out that if we do put drug users in jail, they're almost always rearrested and reincarcerated, often for drug-related charges. Now, let's also bring up the concept of physical dependence and tolerance. Physical dependence is an altered physiological state or neuroadaptation that's produced by the repeated administration of a drug, which necessitates the continued administration of the drug to prevent the appearance of withdrawal symptoms. And tolerance. So, tolerance is an important concept that pretty much everybody doesn't understand right. So, let's go over this one very clearly. You do not become tolerant to a drug. If you were to say that I am tolerant to alcohol, that would be a wrong statement. You do not become tolerant to a drug. A physiological effect becomes tolerant to a drug. And this is very important because, uh, for example, the pain relieving effects of and rewarding effects of heroin, you might become tolerant to those, but you might not become tolerant to the respiratory suppressing effects of heroin because they're that's represented by a different neural mechanism, and every neural mechanism and neural pathway uh, could possibly develop tolerance differently or sensitization differently, depending on the circuit itself and the receptors that make it up. Yeah, it's actually a huge problem if you think about it, that you can become tolerant to some certain symptoms but not others. It's also a huge benefit in terms of some psychiatric drugs that some of us might be taking that for psychiatric disorders like depression. Many of these often come with a lot of negative side effects that are very unpleasant, but in these cases, we tend to become tolerant to some of these side effects and not tolerant or less tolerant to the primary clinical effect. So that would be another example of the divergence of tolerance and why it would be wrong to say, like, I'm tolerant to an SSRI. No, no, no. This effect, has become tolerant to all right, this effect of SSRIs has developed tolerance. Drug dependence, we've already introduced this definition, but here's the actual DSM criteria, where the abuse would have had to occur for at least for a period of time and involve at least several of the following symptoms that I've tried to model historically using IV drug self-administration models. So here what I do is I take an animal and I introduce it, I open up their vasculature and I put a catheter into their vein so that the animal can take their own IV drugs. And then we give them access to the drug under various conditions to model drug addiction. I've had animals self-administer heroin for up to a month, around the clock, 24 hours a day. Interestingly, they start in a very circadian pattern that this breaks down over time. They start off taking it lawfully, like well, during their awake period, let's just say that. And then, just like in humans, later on you see that they start abusing drugs later into their typical sleep cycle. Their overall approach to life changes when the drug is now part of the equation. Now, I want to talk about a couple theories of drug dependence, the development of drug dependence. And here we're specifically going to, these are mainly based off of ideas proposed that are being championed now by George Koob, currently the head of the National Institute on Alcoholism and Abuse. So, he didn't come up with the opponent process theory, and really, this wasn't developed to describe drug abuse either. In fact, I've read the original psychology paper, and in it, I think one of the more interesting examples that they used was skydiving. And the authors pointed out that the first time that you skydive, you're going to be scared shitless, and you're not really going to have much fun. You might be happy that you didn't die when you hit the ground, and that you were brave, maybe a little after you hit the ground. But then over time, the fear begins to dissipate, and the thrill, and it becomes a rush, right? So drug abuse is the opposite of that. The first time that you use drugs, the first time that you drink alcohol, you're usually going to feel all the good effects and none of the bad. That's what you're seeing over here to the left. So a big, positive, like, oh man, this is great, and then no real withdrawal afterward. Over time, uh, however, the negative effects become more pronounced and the positive effects become less so. Uh, so the idea, this is, important because, I think it very much parallels how some drug-dependent people describe why they use drugs later into the process. No, I've never met, a 10-year heroin user that will tell you that they use heroin because it feels good. They will almost always say that they use drugs to get their head straight, is a common expression, or to feel normal again, or to not feel bad, to make the pain go away, to make the misery of the world go away. It's escape, and oftentimes escape from pain that has been induced by the withdrawal from the drug. And withdrawal effects tend to be the opposite of the rewarding ones. And later in dependence, Koob and others have argued that it's like this withdrawal that actually triggers drug craving. That is a theory of addiction. Not everybody agrees with this idea. I've also worked in sensitization labs. So I've worked with some of the top sensitization researchers. Sensitization is this idea that some have argued that some people might start using drugs more because the drug actually produces more enhanced effects in the brain, which would sort of be the opposite of the tolerance that I think tends to go along with the loss of the rewarding aspects of drug abuse. And like where you're left with just the sort of withdrawal symptoms at the end, and you become tolerant to specifically like the positive and rewarding effects. So that's one way of looking at this, one theory. Another theory is that when you use drugs, your dopamine receptors can become more responsive to the drug. So with repeated use, you're making it so the dopamine neurons fire more and more, and that might lead you down the pathway of addiction. I've worked in this area for some time, and I mean, I've published a good bit on that side of the coin as well. I, do think that that can occur. I yes, I personally think that that occurs much less likely, commonly with certain classes of drugs, and I don't know is as involved in the late stages of the addiction process. However, it is possible. I'm not, Marco Layton, I think, did one of the more interesting studies on this because he did it in people. I did all my sensitization work in animals and showed that, intermittency is the big thing that you need to produce sensitization in my experience. So when you give cocaine to an animal, if you let the animal self-administer cocaine like 8 hours a day for 3 weeks, you don't see sensitization, you see tolerance. If you give the cocaine intermittently and let the animal binge once a week for 8 weeks, then you get sensitization. And Marco Layton has demonstrated this in people. And I don't know how he got this approved, but he did it at McGill University in Montreal. And he recruited drug naive college students and gave them amphetamine intermittently and put them in an MRI scanner and showed that those that had the intermittent amphetamine versus placebo had heightened dopamine responses to a challenge treatment of amphetamine later on. Yeah. So, first of all, that study could initiate the addiction process. So, I again don't understand how that got approved, but yeah. Anyway, uh, that is sensitization, and it can occur in people as well. And I think primarily has to do with intermittency of drug use. Marco Layton gave the college students those amphetamine doses intermittently. So what you see up here on the top left graph is what I've already sort of alluded to, associated with the opponent process theory. Initially it might be positive reward or positive reinforcement, reward seeking that drives the drug use. But later on, I mean, I don't know. I've talked with a lot of drug dependent people, and yeah, I have yet to find any in late stage addiction that are using drugs just because the drugs are, very enjoyable. It is usually to fix a problem, something that isn't there anymore. You're filling a hole almost, uh, and whether it's avoiding withdrawal from the pain, in professional worlds, I've already talked a little bit about professional addiction, something that is not, we just as a society tend to turn a blind eye to for some horrible reason. But there it's very common that stress related to the job or career can drive the drug use. In the Baltimore or rural areas that I've lived in, it's oftentimes the just despair, lack of hope, and just horrible living conditions and environments around you that you want to escape. That's portrayed very well in The Wire. Uh, but anyway, and then what you see down here is this idea that that withdrawal or negative effect can lead to sort of a preoccupation or of being on the drug to escape this horrible state. And this is going to lead to persistent, continued drug seeking and periods of binging that lead to greater brain changes and make the withdrawal and negative affect worse, piling it on harder and harder, creating this downward cascade. Innate tolerance is also something to be aware of. This is where you have a lack of sensitivity to a drug the first time you use it. I remember the first time I drank alcohol. Well, in a large amount. I was in, too young of a grade. I won't even say the number, but went out on a camping trip with some guys, and we found some 40 ounces of alcohol that fell off of a truck into our backpacks. And yeah, I just remember going out there and everybody around me was getting sick after one 40 ounce, and I drank two 40 ounces and was finishing theirs. And I thought that was cool. I thought that was a good thing. And boy, do I think differently now. Yeah, that is innate tolerance. Sons of alcoholics, but especially have a reduced sensitivity to alcohol. And it turns out that this is an incredible risk factor. And I mean, like, if you think about it in terms of the drug producing brain changes, and if I have to drink 3 times more alcohol than you do, does that mean I'm also going to get 3 times the brain change and, fast forward through the addiction process much faster? I don't know if it quite lines up as a 1-to-1 ratio, but, you know, certainly taking more drug than another person couldn't be a good thing, right? So, yeah, innate tolerance, huge risk factor for a variety of drugs of abuse. We also have this concept of acquired tolerance. Pharmacodynamic tolerance would be referring from a acquired form of tolerance in which the receptors in your brain change. So this would be in contrast to pharmacokinetic tolerance, where changes things in your liver change. So in pharmacokinetic tolerance, which is, I think, the basis of innate tolerance, possibly, I think maybe I just have more cytochrome P450 in part than others, and the ability to break down alcohol very quickly and efficiently. So that would be pharmacokinetic tolerance. And then as you drink more, cytochrome P450, the enzyme that breaks down alcohol in the liver, upregulates even further. So that would be pharmacokinetic tolerance building up over the innate tolerance. And that keeps going, resulting in you drinking more and more until your liver starts breaking down and becomes covered with fat. At that point, you actually start losing sensitivity, uh, or become more sensitive to alcohol because you're breaking it down less. Well, pharmacodynamic, that refers to changes in the receptors in the brain. So there might be a downregulation or desensitization of the receptor that the drug would bind to, making it less effective. Alternatively, in the case of sensitization, if you're being exposed, especially intermittently with big gaps between each use, you can see an upregulation of receptors, making you more sensitive to the drug. So that would be pharmacodynamic sensitization. You also have this concept of learned tolerance, which is really important. And right, this was first demonstrated in rats many years ago. A scientist, injected a whole bunch of animals with morphine. He then took half of them to another room, and gave them morphine repeatedly for weeks, until they were, they had a large history of morphine exposure. And he kept giving them increasing doses. So then he took half of the animals and took them to a new room and injected them with an even higher dose of morphine, and then gave that same higher dose of morphine to the animals that stayed in their home environment, and found that the ones in their home environment were fine, and those that were in the new environment dropped dead. So, ever hear of this happening before? I'm pretty sure you have. It happens all the time. I mean, how many stories have you heard of a drug-dependent fentanyl user being found dead in a park or in the car in front of the dealer's house because they couldn't wait to get home? And yeah, this is due to learned environmental tolerance. So, in your home environment, in your den, in your drug den, you might be able to take more drugs of abuse than in an unfamiliar environment. Interestingly, there is some distinction in drug class here. Uh, but it's very clear cut with opioids, right? So, and you hear these stories all the time, and this is due to the phenomenon of learned tolerance, that in certain environments, through mechanisms of learning and memory, you can develop the get to the point that you can handle more drug in one environment than another. And I mean, like maybe you've already experienced this and never even really thought about it, but in terms of even alcohol, like how much alcohol you might drink at a club, versus a friend's house, versus a party, versus in your own home. And the effect that is going to have on you is going to be pretty profound. So, this is an example of exactly, what I'm saying. Right. I mean, I just described this exact scenario. Um, right. And Shep Siegel, this was the investigator that performed the initial studies on rodents that I was telling you about. He first did this on morphine, repeated it with heroin. I will say, eventually, Chef Siegel, was discredited. I think it is worth noting his data came out a little too clean, a little too often, and weren't replicated so much by other groups. However, this effect that if you take the opioid-dependent group of animals and then inject them with a higher dose of opium in the same environment or a new one, that one has held up against the test of time. Now let's generally talk about treatment. We've already talked a little bit about methadone. We're going to talk a little bit more about methadone now. But it is worth noting that all treatment strategies are based on the principles that behavior is maintained by consequences, and really based off of general principles associated with psychology. Here we can think in terms of reinforcement and punishment, and also positive and negative. Reinforcement would be an increase in the probability of a response that produces an event. So a positive reinforcer would be an event that increases the probability of a behavior, and a negative reinforcer would be increasing a behavior by removing a stimulus. For example, like removing electric shock from the you are maintaining a behavior to avoid electric shock coming. Punishment would be a decrease in behavior rather than an increase in behavior. So that's the main difference here. So here, you might see a decrease in behavior from the removal of shock. So that would be the difference between negative punishment versus negative reinforcement. And in positive punishment, it would be a case where a stimulus is presented that shuts down a behavioral response. I think this is portrayed well in A Clockwork Orange, where they condition uh, you know music to be associated with a response that is filled with such dread and negative affect that it completely shuts down and suppresses ongoing behavior. Right. So in general, we have several categories of addiction treatment that have been tried in the United States. What you will see in a community varies a lot from what I've seen, from state to state and city to town. You'll see very different things in a city versus a rural environment. In the rural environments in the South, again, I don't remember addiction centers. I think he'd be referred to a church, at least in the small town that I grew up in. Baltimore would have been very different. There you have addiction centers, but the unique community social networks, like that might actually be better in a church in the rural area, are degraded, and at times might be nothing but a grandma. So there are unique problems with all of these environments. But anyway, some of these treatment approaches include agonist maintenance therapy. This would be like treating a patient with methadone or buprenorphine who is on heroin. Antagonist treatment, this would be like giving opioid-dependent patient naloxone and naltrexone. Mu-opioid receptor antagonists do the opposite of the drug. You have outpatient drug-free treatment. This is low intensity, provides drug education. Long-term residential treatment provides care 24 hours a day. Short-term residential programs provide intensive but relatively brief residential treatment. And medical detoxification is the process whereby individuals are systemically withdrawn from addicting drugs to an inpatient or outpatient setting. Detox is typically a precursor of this form of treatment. I want to touch just quickly on AA and NA because they're so common, I think, in America across all states and communities that I've seen. And they're free usually. I've been to these meetings out of support of others, and I can tell you that they survive by just passing around a little offering basket. Like, I mean, that's how they pay the bills and keep the lights on. So that it's accessible and affordable. But the point that I wanted to make actually is that if you're familiar with the psychologist Carl Jung, and you look at the AA program, you will see Carl Jung's fingerprints all over it. And I'm not a Carl Jung guy, so but it's just crystal clear that his thinking in psychology essentially led to the conceptualization of AA. Right. I mean, and correct me if I'm wrong, you better psychologists out there. But the idea is that I think Carl Jung believed that sort of a loss of spirituality and a spiritual side leads to a hole in neuroses that we try to fill with things like alcohol and drugs. So about a third or a fourth of the AA steps are all centered on this, right? Like trying to become spiritually whole again. And I'm most certainly not knocking this at all. It works. It's just not a program I would have ever come up with. But yeah, it's an interesting thing. Carl Jung and AA. To be clear, Carl Jung did not create AA. AA was created by a guy by the name of Bill W. But Bill was in correspondence with Carl Jung and was a big fan. There are several withdrawal techniques that have been associated with both abuse and treatment. But one would be cross dependence, the ability of one drug to suppress the manifestations of physical dependence produced by another, and to maintain the physical dependence state. So this is one that I've worked with quite a bit, and I interestingly have recently shown that cannabinoids can cause cross dependence with opioids. Yeah, I know, right? But anyway, this is a controversial thing, but again, I follow the data, and the data are actually quite clear on this one in my mind. And it is very clear that cannabinoids can lead to tolerance to opioids before you ever use the opioids, and might facilitate the use of larger amounts and higher doses of opioids if you progress to them. But the opposite is also true, that if you are an opioid dependent person, you could take cannabinoids to alleviate some of the symptoms of opioids in a safer manner. Similarly, buprenorphine is that's hitting the nail a little closer on the head. The idea is that CB1 receptors and mu-opioid receptors form dimers and oftentimes have crosstalk intracellularly. But when you're talking about buprenorphine or methadone, there you're talking about directly hitting the same receptor, but you're tickling it rather than hitting it as hard. An antagonist approach would be a drug treatment that blocks the reinforcing effects of the drug. Naloxone is such an example. An aversive agent would make the patient sick. Disulfiram or Antabuse is a perfect example here. You can take this drug, the patient becomes sick when they take it, and that sickness is supposed to discourage future drug use as a punisher. That's also similar to the concept of a Clockwork Orange. Another unique antagonistic approach that's been developed but has not yet been implemented that you should be aware of is viruses. We now have vaccines. And we now have vaccines that can attack and destroy almost any drug in your body. We have a vaccine against heroin. It works actually pretty well. They started developing the vaccine for heroin when I was in grad school. And the issue there is that it worked, but it was surmountable, meaning that, it would be effective if you couldn't afford very much heroin. But if you could afford a good amount of heroin, all you had to do was take twice as much, and you'd be able to still get high. So, but now they have these insurmountable heroin vaccines that you can't get around. So, yeah, who should get the heroin vaccine? We also have one against nicotine. It's going to be a matter of time. I don't think it's going to happen in the US first. I think it'll happen in another country first. And we will see. It's going to be, wow, is that going to be controversial, right? I mean, like repeat drug offenders, are you going to vaccinate them against their will? In some countries, most certainly, I'd say I see that coming down the pipes. And then, yeah, think about the ethical ramifications of that. I don't know. Yeah, that's one that I see that just hasn't been applied yet. Now, I also want to point out that addiction is a brain disease. And I think that this is an important concept. This is a quote from Alan Leshner, the previous head of the National Institute on Drug Abuse when I was a grad student. Understanding addiction as a brain disease explains in part why historic policy strategies focusing solely on the social or criminal justice aspects of drug abuse and addiction have been unsuccessful. They are missing at least half of the issue. If the brain is the core of the problem, attending to the brain needs to be a core part of the solution. So, here I realize some people feel very strongly about the social aspects of addiction. And this isn't to say that those things aren't important. In fact, I believe I've tried to make very clear that addiction is a process that can be fast forwarded by things like social and environmental factors. Yeah. But all of those are acting on the brain. We think that addiction is a brain disease because drugs change the way the brain works. Changing the brain changes behavior. Drugs-induced brain changes can linger for many years. The brain may never go back to normal. Treatment is needed to help abusers cope with their brain changes, and research is needed to better understand what those changes are. So all drugs of abuse target the mesocortical limbic dopamine pathway initially. I've published a ton on this. I have shown how a wide array of different drugs alter dopamine release in this pathway. George Koob and a few others tried to make the argument that opioids do not actually increase dopamine release in this pathway. That's not correct. I mean, I've published this myself multiple times. It does too. All drugs of abuse increase release in this pathway. This pathway was, I argue, naturally selected for because it draws us toward things that are highly valuable and would be advantageous for our behavioral fitness. These can be rewards, but are not limited to rewards. Drugs trick you into thinking that this is a much better value than it is. And that's the first domino of the brain problem. And, so if you have a lot of other valuable things in your life, I think that will slow down the addiction process to you. If you have very few valuable things in your life, if life is very rough, if you're homeless in Baltimore, if you are from a rural area and see no way out, and there are ways out, I promise you, I found them. They do exist. Keep looking, please. But if you feel this hopelessness, Uh, right. I think it becomes very evident why a highly valued like trick could be so powerful. I mean, this is just the dopamine pathways in the brain. Right. I mean, they project, really pretty profusely throughout. Uh, they, most importantly, though, project to the striatum, which is part of the basal ganglia and is involved in stamping in habits. They also project to the frontal cortex, which is important and involved in executive function and decision making, also highly related to drug dependence. But it's much more complicated than just dopamine. I'm a dopamine researcher that's made his life on, or made his career on documenting how drugs of use alter dopamine release. But dopamine is not the end all be all about addiction. If anything, I would argue that dopamine becomes very boring in late stage addiction. I think dopamine drives the original drug seeking, and then over time you stop, at least in my hands, unless you're giving the drug intermittently to the animals, you almost always see tolerance develop to the dopamine releasing effects of the drug. Again, I mean, I think this parallels just this idea that you're not taking the drug because it feels good in late stage addiction. You're taking it for other reasons, like avoiding pain and through mechanisms of learning and memory that have, yeah. So it's much more complicated than to think that it's all just dopamine in one pathway. There are many pathways that are involved and many neurotransmitter systems. Now I'm going to briefly run you through some of the main pharmacological agents that are abused and give you just a very brief summary of some of these. Starting with opioids, there are three main opioid receptors in the brain: the mu, the delta, and the kappa. Heroin is rapidly converted to morphine, interestingly, in the brain, and morphine is what's actually binding to mu. Heroin is, more addictive than morphine because it absorbs, it passes through your tissues faster than morphine itself, making it more addictive. And this is similar to different routes of administration as well, and treatments that people have used. Crack cocaine, has, in freebasing, were ways that cocaine was adapted to make it hit the brain faster. Uh, so that is really why heroin is more addictive, but than morphine. It's just speed of onset, and more gets through as well. But anyway, actually converts to morphine before it binds to the mu opioid receptor, which is most responsible for its abuse properties. There have been studies by Steve Negus and others that have demonstrated that the mu opioid receptor is the one that's necessary for heroin to be self-administered. Delta does play some small role here. Kappa is the oddball. Kappa is sort of the opposite of the mu opioid receptor. Whereas the mu opioid receptor, activating it tends to produce analgesia and feelings of reward and well-being. When you activate kappa, it makes you very anxious and unsettled and uncomfortable. Kappa is activated by another drug that is abused by some people that I honestly don't think has any potential for dependence, because I don't understand why people abuse it, and that is salvinorin A. Salvinorin A, or salvia, is a drug that I guess can put you in a dissociable state, but it's going to be an incredibly unpleasant dissociable state. I mean, I don't know. I can teach you many better ways to get into a dissociable state without having such unpleasantness. They're out there, trust me. So yeah, I never understood the salvinorin A thing, but yeah, kappa activation actually is a little unpleasant. Symptoms of compulsive use of opioids include high prevalence of depression, deaths, medical complications, infections. In Baltimore, where I was from, they have one of the highest HIV rates in the country. Most of this comes really from a combination of needle use and unprotected sex. You also can get foreign body emboli. This is portrayed well in the drug movie. Um, uh, uh, the name is blanking on me. The same director just made The Whale, not Train Spotting, Requiem for a Dream. Opioids also have a very clear withdrawal syndrome. Opioids are probably have this stereotypical withdrawal syndrome that people think of when they think of drugs. That I think was portrayed really well in the movie Trainspotting. Opioid treatment is typically done with methadone, more commonly these days with buprenorphine. Suboxone and Subutex are the two things you're going to hear of the most. Suboxone has naltrexone and naloxone added to it. This is primarily done to prevent the patients from taking the drug IV, because that would make them a little sick to take the naltrexone or naloxone IV. Subutex is just a buprenorphine by itself. My own data show that buprenorphine functions as a partial dopamine receptor, like a partial agonist for the mu opioid receptor. And as a result, but at high dose, it seems to function as an antagonist. And that's something that I think is super cool and underappreciated. And it can function as an antagonist to heroin, because it does a bad job at binding to the mu opioid receptor. It's sort of like a weak binder, whereas heroin binds very well. Well, morphine, right? Morphine binds very well. So buprenorphine would, if it were on board before you took heroin, heroin wouldn't be very effective. So in this way, it is sort of like an antagonist by itself. And I don't know that you necessarily need the naltrexone part, but anyway. So buprenorphine or methadone, the overall idea, the goal that you're going for is that you want to maintain a steady state level of drug in the blood. With heroin, it's typically associated with these crashes and, drug-seeking periods. The issue here is that is not very conducive for functioning in society. So, one of the issues that, people tend to present with the methadone or buprenorphine is that, you're trading in one drug for another drug. And while that is true, you're trading in one drug that makes you not socially functional to one that makes you socially functional. So I guess my goal would be to get the patient so they can be a functional parent and employee. That I think is a reasonable goal. What addiction treatment looks like is actually an interesting consideration. The idea that somebody goes back to being who they were before they started abusing drugs, I don't think is a fair outcome. I don't think AA would approach it this way, right? And nor do I think anybody that had been around drug dependence quite a bit. And but I don't mean to say that in any way that brings out despair or a lack of hope. Recovery is a wonderful thing, and you could actually turn into somebody who's better than you were when you started. But your brain has been changed, so you don't just go back to square one. Things are going to be a little different moving forward. Methadone maintenance, although some truly can abstain from methadone and still have a reasonable hope for stable long-term recovery, overall research has found that up to 80% of patients who quit methadone relapse to opioid abuse within 3 years. In recent years, a gathering consensus has endorsed methadone maintenance as a chronic, potentially lifelong treatment, which is my point here. So
I personally have, like, I can understand how it would be reasonable to be in a situation where you might be on buprenorphine for the rest of your life. And I guess I would favor that scenario over one in which, things like, as long as you're staying off the heroin itself, and even if you're on heroin, if you're taking the buprenorphine as you should, the heroin isn't going to be very effective when you're on the buprenorphine. So to me, it's not the end of the world. However, I completely understand the other perspective as well. This is controversial stuff, right? Like, the idea of being on buprenorphine or methadone the rest of your life. Let me put it a different way. How do you feel about your child being on buprenorphine the rest of their life? That makes it seem a little different, right? I can see why you would want to do anything but that, including subjecting them to like a Clockwork Orange type situation. And I don't know. I don't know. I don't have the perfect answer. If I did, we wouldn't have an opioid problem now, would we? Alcohol, is a big problem in America. About 2/3 of all adults use alcohol occasionally. It's very common to abuse it as well, and abuse is common. It used to be pretty regular to see liquor in, offices at work. Lifetime prevalence of abuse is very high. It's been 5 to 10% in men, 3 to 5% in women. And again, like, how this is looked historically as a function of sex is an important consideration. It's possible that, the drinking patterns of the women did not actually were alcoholism, uh, or but might not have been interpreted that way. Uh, Mechanisms of action. Alcohol has many different binding sites. In fact, I think it's fair to say that we don't know how alcohol works on the brain. And I would even go as far to say that it's one of the greatest embarrassments in the field. That I think we should be pretty embarrassed that we can't tell you how alcohol works in the brain. I can do a bunch of hand waving, and here I'll do some of it. So we do know that alcohol does have some effects on the GABAergic system. It seems to have some effects like benzodiazepines, and benzodiazepines, which bind specifically at the GABA A receptor, can be potentiated by alcohol. But alcohol is doing more than that, and it's not doing all that incredibly well either. It's also been suggested that it has intracellular effects. Uh, I don't know. Another weird thing about alcohol, I think one of the weirdest things about alcohol is how much you need of it versus other drugs, which is, I think, one reason why it's become so common as a social like drug that we just use routinely. Is that you can take tremendous amounts of it and not fall down. It takes, you have to consume gallons sometimes to fall down. I mean, like, what other drug is like that? I mean, like, you don't see in Baltimore, people didn't build beet pyramids. You have beer pyramids, right? I mean, like, what? Yeah, it's a strange thing. Alcohol's effects are additive with other CNS depressants like benzodiazepines, like I said, and it can have pharmacokinetic and pharmacodynamic tolerance. Recall, pharmacodynamic tolerance would be a change in the receptors in the brain. Pharmacokinetic tolerance means that I'm getting more enzymes in my liver to break down alcohol. Alcohol also has a very pronounced withdrawal syndrome. Really one of the worst withdrawal syndromes, maybe even worse than opioids. The withdrawal can kill you. You can go through seizures. it can be very dangerous to quit drinking cold turkey if you are a chronic alcoholic. There are, various treatment approaches. We've already touched on Alcohol Anonymous, inspired by the work of Carl Jung and his ideas involving spirituality and community support. Uh, and I think for what it's worth, I think it would be fair to say that AA and NA are as effective as any pharmacotherapy approach that I have to sell you. I kind of feel a little like I'm a neuropharmacologist. I am not a young guy. I'm not, I have no love for the 12 steps. They say things that I don't necessarily agree with, but I'm a scientist at the end of the day and I follow the data, and AA has an incredible track record of working. And again, with addiction, you have to have tempered expectations, right? But I don't know that I would necessarily say that I have a better neuropharmacological answer than AA or NA at this point in time. Disulfiram is another way to go. Yeah, like my issue with things like disulfiram are, it takes an incredible amount of willpower to take something like that. If it's not being forced on you, and I also don't like forcing drugs down other people's throats. Nicotine has a, pretty pronounced withdrawal symptom as well. But here you're going to have a lot more irritability and impatience and anxiety. Cannabinoid withdrawal shares some more similarities to nicotine withdrawal, although they are still minor relative to nicotine. One thing, though, with cannabinoids is recall that they're so fatty, they stick in your fat. So they sort of come with their own built-in agonist therapy that is time released over the course of 2 weeks after use. So like when people say that and what's really interesting is that, so I've taken cannabinoid dependent animals, and I know that they're cannabinoid dependent because what I do next is that I challenge them with a cannabinoid receptor antagonist. And when you do that, you make the animal very irritable and impatient and hostile. You see these withdrawal symptoms really come out. So I think that there is a very pronounced, actually, an underappreciated cannabinoid withdrawal syndrome that is basically treated by its own built-in agonist therapy that's there for 2 weeks after you use it, stuck in your fat. But with nicotine, you don't get that. You would have to take that a nicotine patch or chew the gum, to get that slow time release that might help you deal with the withdrawal symptoms. Cannabinoids are the most commonly used illicit drug, I guess illicit depending on what state you're in. Yeah, I mean, I just traveled across the United States. I'm back here in Colorado right now and, legal again, but passed through a whole bunch of states where it was illicit. Cannabinoid receptors have been identified in the brain. A member of my PhD committee was actually the person who discovered the cannabinoid receptor. At the time, everybody thought the cannabinoids, because they're lipophilic, bind to the lipid bilayer and make it all wonky and make you high. And yeah, I mean, like that's crazy, right? But Lynn Howlett first discovered that cannabinoids are binding to a G protein coupled receptor, later cloned by Raphael Mechoulam, who also discovered anandamide, which he named after the Latin term for bliss. Anandamide is actually not the most common endocannabinoid. The most common endocannabinoid is 2-arachidonyl glycerol. But anyway, these, the exogenous cannabinoids act on the same receptors as the internal cannabinoids in your brain. You also have internal opioids in your brain that act on the opioid receptors. Interestingly, if one drug that I worked with that is a cannabinoid receptor antagonist called rimonabant, that drug was shown to be very effective at treating obesity and drug abuse. because I showed that, basically it eliminates, interestingly, through complex mechanisms. I'm not going to completely get into it, eliminates the ability of conditioned cues, like a predictive stimulus that has come to associate and predict the value of the drug to do so. So yeah, you essentially lose the value of the McDonald's arches to make you go get that value meal, or the needle to go get the bag. But the crazy thing about Rimonabant is when they transitioned that to clinical trials, yeah, people started killing themselves on it. Now, I still am a little like, were some of these patients going to commit suicide anyway? I don't know. But it's also made me think a little bit more about maybe endocannabinoids and cannabinoids are pretty important for well-being. And if you block that system or challenge that system, you might increase suicidal ideation. And this could actually be a big deal in cannabis dependence, because if you're using exogenous cannabinoids all the time, your endogenous system is going to become reduced in its prevalence and signal. And yeah, so what are the outcomes of that going to be 10 years down the road? I don't know. I guess we'll find out. Hallucinogens, Denver's new favorite drug. We've moved on from cannabinoids. We're now a psychedelic center. There tends to be very little evidence of drug dependence resulting from psychedelic drugs. Psychedelic drugs come in different flavors, different classes. Chemically, the ones that act on serotonin tend to come in two main flavors: those that look like serotonin and those that look like dopamine but still act on serotonin. MDMA and mescaline are examples of ones that look like dopamine but still act on serotonin systems. Psilocybin and LSD are examples of ones that look like serotonin and primarily act on serotonin. You also have non-serotonin acting hallucinogens. Ketamine, dextromethorphan are good examples of NMDA receptor antagonists that are acting on the glutamate system. These tend to make more auditory hallucinations, so they're very popular at like the club. Whereas LSD and the MDMA are going to produce more visual hallucinations. Addiction is like other diseases. It is preventable, it's treatable, it changes biology, and if untreated, it can last a lifetime. Now, I'm waiting for someone to message me to go do some recordings here at the University of Colorado, Denver, where we're going to try to measure some dopamine. But seeing how they haven't messaged me yet, I'm going to spend 5 more minutes talking about psychedelics and psilocybin. You may feel free to stop me at any time by hitting mute or just crossing this out. But seeing how we just measured decriminalized psilocybin in Denver, you might want to know a little more about it. So there is one person that I would tell you to look up is Roland Griffiths, Griffiths. He's written and researched. He's a conservative pharmacologist who has researched this subject for many years. He is not an activist in my mind. That's one of my big issues in this area, that I see there's a lot of activism that and I find it a very interesting time right now in society, finding the line between activism and objective science. I like to think of myself as an objective scientist that approaches the idea of psychedelics with an open mind, a neutral perspective. I am not for psychedelics. I am not against psychedelics. I am, for scientific exploration and understanding. And psychedelics, Roland Griffiths and others like him that are not activists have clearly demonstrated beneficial effects of psychedelics in a variety of untreatable, hard to treat mental conditions, including post-traumatic stress disorder, Now, how might something like psilocybin treat PTSD? There are a lot of different answers out there. One, going back to Carl Jung, is the idea is that they restore wonderment, which can be interpreted as spirituality. They might create a little like things might seem cool again, or like novel, and you just it's amazing how much just getting out in nature and feeling the grass under your toes can make you appreciate being here a little bit, right? And yeah, maybe it actually makes you notice the grass. Um, so that's one. Another that's very people love to talk about, and there's very little evidence to support this one yet, but it is an interesting theory, and that is that it sort of makes memories more labile and allows for reprogramming of the mind. The government got into this idea a few years back too, and experimented with the idea under the experiments known as MK Ultra project. If you've never heard of the MK Ultra project, it's where the government, gave LSD to soldiers, and a disproportionate number of people, of privates, that were from low socioeconomic and racial minority backgrounds. And well, yeah, demonstrated that, yeah, LSD might be, maybe could create, make the mind labile, but it's not going to be very useful in extracting information during interrogations, which is really what they were doing to these poor privates after forcing a good bit of LSD on them. LSD has also had its time in the light of social change. And, here, this is a whole interesting story as well. So there was a famous psychologist at Harvard University. And, he had a research lab at one point in time, and then got big into the idea of promoting the use of LSD to open one's mind. I guess in modern terms, you might say to make one woke. And, yeah, took it upon himself to sort of, promote the rapid cultural use of LSD amongst all the youth around the country. And so people didn't like this and found a reason to throw him in prison. Interestingly, he was broken out of prison by a group called the Weather Underground, who funneled him through their underground railroad all the way to Africa, where he ended up. And last time I heard, he like angered a ruler over there, and ended up in some deep trouble. But there has also been this long-standing idea that maybe it could change one's bigger perspectives on life to the point that you are making marked changes in society. Now, whether or not how we should approach that, I don't think that there's one clear answer to. It's just an interesting thought to chew on. That has happened historically, and now that we're decriminalizing these things, and I think there's going to be more acceptance of use, that you could see both complaints and advocates for using it to induce social change. The last thing I wanted to touch on is, are there downsides? So, I mean, we already know that psychedelics have very little risk for drug dependence. But there is one concern for me personally, and that is I am not convinced that psychedelics are not going to bring out psychiatric symptoms in some patients. I mean, again, I cannot prove chicken or the egg, whether drug use brings out mental problems or mental problems lead to drug use. All I know is that I'm a data guy. I am wary of data. there's that clear correlation between even cannabinoid use and the onset of mental disorders. I find it pretty easy to accept actually that if you have 100 patients, there might be a few that have mental like issues brought out by experimenting with psychedelic drugs rather than being of a benefit. So, I mean, my question for you is, I guess, where's your ratio of acceptance on that one, if you believe it at all? So, I mean, maybe your answer is that, you don't believe that they will cause harm in anybody, in which case, you have your ratio is one, where, psychedelic positive check one over, zero. Alternatively, think of it in terms of 100 patients. So let's say if we think psychedelics might help 90 patients and cause mental disturbances in 10. So I mean, there your ratio is going to be 9, right? So right, it or point well, but my point, what I wanted, like, I just want you to reflect on the balance between the benefits that could come from psychedelics to the negatives, and in terms of policy, how we can balance that potential for both. And in general, like, that's how I wish that drugs were approached in the United States from middle school on. I mean, maybe even as elementary school, I don't know. But I mean, like, I'm not here to indoctrinate you or bias you to go out and free your mind with psychedelics. I'm not here to bias you and tell you that drugs are awful and going to lead you to, a place of ill repute. I think that all drugs have good and bad effects that are going to vary depending on the individual. And that's just the reality of how you should look at drugs in my mind when you approach them. The idea that psilocybin is a gift from God that's here to cure all of our problems is, I think, as wrong as saying that it is a tool of the devil or the tool of the communists. I mean, like, that's equally absurd in my mind. So anyway, it's been fun. I will send out, an announcement soon. Hopefully, get some last feedback from you guys. Have a great end of your semester, and let me know if you have any questions.